Okay, so we'll get started with our next presentation. So our next APP is Caroline Pearson. So Caroline received her Bachelor of Science in Nursing from Louisiana State University. She worked as an RN in New Orleans for several years, then pursued her Master's of Science in Nursing at the University of South Alabama. She later pursued a hospital medicine APP fellowship, where shortly after that is where we got to know Caroline, and we're very fortunate enough to get her on our team. After her fellowship, she joined our APP team here at the University of Colorado. She had a brief stint at UT Southwestern, also in Texas. When Caroline isn't working, she enjoys skiing, hiking, running, traveling, and exploring Colorado with her husband, Dylan, and their two children, Lexi and Jake. She is an avid LSU football fan and enjoys cooking Cajun cuisine despite being in Colorado. So please welcome Caroline for her talk on B-cell lymphoma, a case-based approach to disease presentation, workup, complications, and treatment strategies. Thanks, Caroline.
Thank you for the lovely introduction. I don't deserve that. So my topic of choice was lymphoma. And obviously, as everyone knows, there are over 90 different types of lymphomas. So we had to kind of zero in on a subtype. And I chose B-cell lymphomas due to seeing this most commonly in clinic and in the inpatient setting. And so we'll be looking at a case-based approach to different disease presentation, how to work up these patients, as well as complications that can arise with treatment and some treatment strategies. Some objectives for today are to identify a clinical presentation that would warrant a workup for lymphoma, as well as to describe and differentiate between first-line therapies in B-cell lymphomas, as well as to recognize complications that can arise with treatment. And I do not have any disclosures related to financial relationships. So what is lymphoma? Lymphoma is a very heterogeneous blood cancer of the lymphatic system. And the picture in the middle depicts the different parts of the lymphatic system, which extends beyond lymph nodes. Picture over to the left shows an enlarged conglomerate of lymph nodes, and the picture on the right shows a picture of abnormal B cells consistent with diffuse large B-cell lymphoma. So again, there's over 90 different subtypes of lymphomas, and it's very highly variable, with lymphoid malignancies ranging from the most indolent of diseases to some of the most aggressive cancers in humans. And lymphomas are broadly classified into either Hodgkin's versus non-Hodgkin's lymphomas. And so Hodgkin lymphomas make up about 10% of lymphoma cases. They tend to be on the younger end of the spectrum. And this we see this most commonly in the outpatient setting. It's pretty rare for us to see a Hodgkin patient in the inpatient setting. Next, we have the non-Hodgkin lymphoma cases, which make up about 90% of lymphoma cases. And these are further characterized into either being T or NK cell lymphomas or B cell lymphomas. And then each of those subtypes are described as either being an indolent or aggressive type of lymphoma. And today we're going to be focusing on two different subtypes of aggressive lymphomas, including high-grade B cell and diffuse large B cell lymphoma. So where does lymphoma originate? So in the picture at the top left, you can see depicted the bone marrow, which shows some B cell precursors, which then turn into naive B cells and eventually an activated B cell. The picture in the middle depicts an enlarged lymph node, and it shows the different regions in which different subtypes of lymphomas originate, with the mantle zone being the outer ring. And this is where MCL or mantle cell lymphoma is thought to originate. Then we have the germinal center portion of the lymph node where Burkitt's lymphoma, follicular, and germinal center diffuse large B-cell lymphoma originate. And then post-germinal center, we have activated B-cell like diffuse large B-cell, primary mediastinal B-cell, and classical Hodgkin lymphoma. And for those that really like science, at the bottom here in the light blue boxes, the red, the type in red is different molecular gains, and then in blue are molecular losses that these patients can express. And then at the very bottom in green are the immunohistochemistry stains that can help us and the hematopathologist determine the subtype and prognosis. So now we're going to get into our first patient case. So we have a 64-year-old female who presented to her primary care physician with new complaints of dull left upper quadrant pain, as well as just generalized abdominal pain and just not feeling well. And she reports this has been happening for about 2 weeks, just not getting any better. So she decided to get checked out. She also endorses some new abdominal fullness, which caused a decrease in appetite and some early satiety or just feeling full more easily. She's also had 20 pounds of weight loss over the last 2 months without trying, as well as some intermittent fevers and drenching night sweats. She's still able to go to work and perform her activities of daily living, but she's just feeling more tired than she feels like she could. So what happened next is they performed a physical exam. And her PCP noticed, again, generalized abdominal tenderness and noted some distension on exam, but no palpable spleen, no palpable adenopathy. So what should we do next? So the PCP decided to go ahead and get a CT scan, in which it showed some multiple intra-abdominal and large lymph nodes. So she sent them to our IR colleagues and had a core needle biopsy done on one of these retroperitoneal lymph nodes that was concerning for lymphoma. So before we kind of get into how we're going to treat this patient, we need to know, how do we diagnose this patient? So again, clinical presentation or just a good history and physical is really kind of the mainstay of diagnosing any disease. But specifically in lymphoma, some of the presentation can include painless lymphadenopathy, palpable masses, organomegaly, specifically liver and spleen enlargement, as well as pain that can't really be attributed to any injuries or trauma, and any other progressive symptoms that are just difficult to explain. We also look for the presence or absence of B symptoms, which include fevers, weight loss greater than 10% of the patient's body weight in less than 6 months, as well as drenching night sweats. Most patients, prior to them presenting to their HEMONC team, will also have a basic workup of CBC, BMP, LFTs, FOS, uric acid, LDH. And then ideally we get a PET CT scan. This is more sensitive than just a CAT scan, as it shows how active the tissues are rather than just how large the nodes or organs are. And then we obviously need a biopsy for diagnosis. So tissue biopsy, obviously required for diagnosis, given there's so many different subtypes. In a perfect world, we'd get the whole node removed. This is the gold standard, but as we know, this is rare. We rarely are able to get patient into surgery in a timely fashion. So it's pretty rare to get this excisional biopsy. Next best thing is the core needle biopsy. And this is again, appropriate if we cannot get an excisional biopsy. The reason why we prefer this over a fine needle aspirate is just it's a larger tissue sample, so we can run more of the advanced tests, including FISH and cytogenetics. We're really not able to do that on a fine needle aspirate. And the pathologists are also not really able to look at the histologic grading on a fine needle aspirate as well. So what tests do we want to run? So the first test that the pathologist will do is just looking at the cell itself, looking at the tissue itself, and this is called morphology. This is where they study the cell population and look at the overall architecture of the lymph node or the sample. Followed by flow cytometry or immunophenotyping. And this is where we look at proteins on the cell surface to look at the cell of origin. And then lastly, we look at cytogenetics or FISH, which is also known as fluorescence in situ hybridization. So this is when they take a fluorescently dyed DNA probe to look for a specific chromosomal abnormality. So basically, once they say, this is looking like diffuse large B-cell lymphoma, then we say, okay, well, I want to FISH for MYC, BCL2, BCL6. So probing a little bit further into FISH and cytogenetics. So why is this important? So specifically in diffuse large B-cell lymphomas, knowing their FISH studies helps us know their prognosis, and it also helps us choose which first line therapy we want for the patient. So specifically these oncogenes, MYC, BCL2, and BCL6, if a patient has 2 out of 3 of these or 3 of these, that we know that they have a poor prognosis. And there have been studies that have shown that these patients have a worse progression-free survival in the standard of care regimen of R-CHOP compared with those that do not have these oncogenes. And we used to call this double hit or triple hit lymphomas, but now it's called high-grade B-cell lymphoma and is considered a separate subtype of diffuse large B-cell lymphoma. So due to the fact that we know they do worse with R-CHOP, there have been studies that have tried to show what would be the optimal therapy, and if they get a more intense regimen, do they do better? And they do better with a more intense regimen, but there's not a consensus in what regimen is the best for these types of patients. Here at UC Health, we typically use dose-adjusted R-EPOCH for these patients, as this has shown an improved complete response rate over R-CHOP and has less toxicities than some of the other intensified regimens that have been studied. So now, once we get a diagnosis of B-cell lymphoma, what else do we need to do? So we need to look at the patient's fitness, their performance status. Do we think they're well enough to receive the chemotherapy that we want to give them? In younger patients, we also need to talk about fertility preservation, as we know that once they receive the chemoimmunotherapy, we can't take it back. So ensuring that they've at least got the reproductive counseling and possible do the fertility preservation. We also want to get a TTE or echocardiogram to ensure that their heart is healthy enough to receive certain chemotherapy subtypes like anthracyclines. We get a beta-2 microglobulin, as this can be elevated in diffuse large B-cell lymphoma, as well as a vitamin D level. There's actually been studies shown that patients with lower vitamin D levels don't do as well as those that were given vitamin D supplemental or had a normal vitamin D level. So we routinely test and treat patients for low vitamin D levels. We obviously want to make sure the patient isn't pregnant prior to treatment, and then giving the patient an option for a central line, such as a port or PICC line. And then in select cases, we'll do a bone marrow biopsy. This is mainly done in limited stage disease, as we want to make sure their disease isn't more advanced than we think based on the PET, because this could impact the amount of cycles that the patient receives, as well as in lumbar puncture. So if someone presents with headaches as a presenting symptom, you would want to do that at diagnosis. And then possibly additional MRI, such as brain MRI, MRI spines, just depending on the patient's presentation. So getting back to our patient, so again, they had a core needle biopsy, and it was found that they had diffuse large B-cell lymphoma. And their specific subtype was germinal center B-cell. And they did have FISH studies done that showed a BCL2 rearrangement, but thankfully nothing in MYC or BCL6. And I've shown 2 pictures here, one on the left showing how they obtain a core biopsy, and then you can see on the right that they're actual very large samples of the tissue, so they can actually run all the tests that they want and not just tiny little cell samples. So again, before we pick a therapy, we need to look at the stage. So we use the Lugano classification for staging, and this is based on the extent of disease on imaging. Stage 1 involves just a single lymph node region, and stage 2 involves 2 or more lymph nodes on the same side of the diaphragm. Stage 3 involves multiple lymph node regions on both sides of the diaphragm, with stage 4 being most advanced, with having diffuse or disseminated involvement of an extranodal organ or tissue. They also further characterize and qualify the disease by either the presence or absence of B symptoms, so either A or B. If they have extranodal disease, it's qualified via an E, or bulky disease, which is defined as a single mass greater than 10 centimeters, and that's designated by X. So our patient went on to get a PET CT scan, and in her abdomen and pelvis, she had multiple focal, intensely avid retroperitoneal nodes, much of which were confluent. A node along her right diaphragm, a confluent prevascular nodes in the central abdomen, with the largest being 2 centimeters, and a large periaortic conglomerate of nodes, with the largest being 2.2 centimeters. In her chest, she did have a node in the left supraclavicular area measuring only 7 millimeters. So based on this, does anyone want to take a stab on her staging? And if not, we'll get to it in a minute. All right. So again, before we pick her treatment, we also need to think of other considerations beyond just stage and disease type. Again, we've talked about performance status or functional status. We also have to think about if they have comorbidities such as CHF, liver disease, kidney disease, their age, are they 80 or are they 18? An IPI score, which I'll go over in the next slide, which is the International Prognostic Index, and this is used in B-cell lymphomas. And then their molecular subtype. So this image shows germinal center B-like versus activated B-like. So we know that patients with germinal center disease do better than those with ABC subtype. And then the FISH and cytogenetics. So again, we've already went over that patients that have these 2 of 3 of these oncogenes have a worse prognosis. So these are factors that we need to consider when looking at their treatment. So again, IPI, or the International Prognostic Index, this is something that the physicians do prior to picking the patient's therapy. And it's an objective prognostic index. So they look at their age, serum LDH, their performance status, their stage, and if they have extranodal involvement or not. The higher the score, the worse the prognosis. And there's also a separate IPI score for central nervous system. And this is used to assess the risk for CNS disease. So it includes the same few subtypes or variables at the top, but it also includes whether or not they have kidney or adrenal involvement. And then again, the higher the number, the higher the risk for CNS disease, although it is controversial as to whether or not to prophylax, but that's another topic for another day. So how do we choose a therapy for our patient? So we look at the NCCN guidelines, and this is specifically for diffuse large B-cell lymphoma. And first, they break it down into stage, either early stage disease 1 or 2 versus bulky stage 2 or stage 3 and 4. And our patient, I'm probably jumping the gun a bit here, but our patient has stage 3 disease, so we need to look at what is recommended for her. But before we do that, I wanted to get into a little bit about the historical care of diffuse large B-cell lymphoma. So R-CHOP has been around since 2006. So this has been the standard of care for these patients since rituximab was approved. And before that, CHOP has been the standard of care for over 40 years. And this cures a lot of patients, but not everyone. So who is this appropriate for and who is it not? So patients with germinal center B-cell have a 5-year overall survival of 78 to 80%. And those with the ABC subtype only have a 5-year overall survival of 45 to 56. And worse yet, those with the high-grade B-cell lymphoma only have a 5-year overall survival rate of 22 to 27%. So we've got to do better. So when looking at treatment choices for our patient, we're going to focus on the second column from the left because she's stage 3 disease. So you can see there are 3 preferred or 3 recommended regimens, with 2 being preferred. The first being R-CHOP, which is long been the standard of care, as we just mentioned, versus Pola-R-CHP, which is a newer therapy over the past few years. And this is considered for patients that have an IPI score greater or equal to 2, that do not have a high-grade B-cell lymphoma subtype. And then lastly, there's dose-adjusted R-EPOCH that we consider for those with high-grade B-cell lymphomas, as well as other subtypes such as HIV-associated primary mediastinal B-cell lymphomas, et cetera. And then let's compare these 2 R-CHOP and diffuse and dose-adjusted R-EPOCH. So R-CHOP is, again, been around for quite a long time. This is typically given in the outpatient setting every 21 days with doxorubicin and vincristine given over about 5 to 10 minutes pushed, cyclophosphamide over an hour, and rituximab over several hours, depending on what cycle. And prednisone's given orally days 1 to 5. At our institution, we don't typically prophylax with G-CSF or Levaquin, and we typically will get an interim PET before cycle 3 to see how the patients responded and then give additional cycles based on the stage. And then for our high-grade B-cell lymphomas, as we've mentioned, we tend to do dose-adjusted our EPOCH, which is a more intensive regimen. It's the same immunochemotherapy backbone, but adds etoposide. And so the etoposide, vincristine, and doxorubicin are given, and we call it a triple bag. They're hung for 24 hours, 4 days in a row, and then followed by an cyclophosphamide over an hour on day 5, and then rituximab given either on day 1 or day 5, depending on what cycle the patient's on and how high risk they are. This is typically given inpatient, although there are some institutions that will send patients home with a continuous pump. This is also every 21 days. And these patients, just due to the nature of this being a higher intensity chemotherapy, they do need the G-CSF prophylaxis. And then we give patients Levaquin and fluconazole for 10 days or during their nadir when they're neutropenic. And again, our institution also does an interim PET CT scan prior to cycle 3, and we typically do 6 cycles plus or minus some CNS prophylaxis, which again is a little controversial. So the new combo of the block, probably dating myself by picking the nucleids on the block, but I had the sleeping bag, you know. So Pola R-CHIP. Pola R-CHIP is a new combo that was FDA approved in April of 2023. And this was approved based on the POLARx clinical trial, which was a randomized, double-blind, multinational clinical trial in which they took patients with newly diagnosed high-grade or diffuse large B-cell lymphomas and randomized them to either R-CHOP versus Pola R-CHIP. And their primary endpoint was progression-free survival. And what they found were patients, specifically with an IPI score of greater or equal to 2, had a better progression-free survival with Pola R-CHIP compared with R-CHOP. So this is now an NCCN recommended first-line therapy for these patients. Again, this is given every 21 days, and we do this in the outpatient setting as well. The polatuzumab's mechanism of action, it's a CD79B antibody drug conjugate, and this binds to B cells, delivering a cytotoxic dose of this monomethyl auristatin E, or MMAE, which is a microtubule inhibitor. And this does have significant neurotoxicities, especially neuropathy. And as you can see, vincristine is omitted from this combination. So you should always assess for the presence or absence of neuropathy before giving this treatment. So now back to our patient. Let's choose therapy for her. So she is considered stage 3 due to her having disease above and below the diaphragm. And she did have B symptoms, as remember, fevers, drenching night sweats, weight loss. So based on that information, she qualifies for NCCN recommended R-CHOP, Pola R-CHIP, or dose-adjusted R-EPOCH. Now, looking further, she has standard risk subtype with GCB. And then her FISH was positive for BCL2, but thankfully not MYC or BCL6. So she is standard risk. She did have a high IPI score due to her age over 60. She had a stage 3 disease, and her LDH was elevated. So she's in that high intermediate group. So again, this is just kind of going over other factors that we need to think about when we're considering what therapy to choose. So what should we give her? She was treated with Pola R-CHIP, and she received 6 cycles of this. She did very well with it, and she had a complete response on her end of treatment PET and no relapse as of her last imaging. We're going to go over 2 other cases that we'll deal with some other complications that can occur with treatment, and they're much shorter patient cases. I know everyone's probably ready for lunch, so almost there. So now we have another 64-year-old. I just realized I did two 64-year-olds, so sorry about that. 64-year-old male with a history of hyperlipidemia who presented with worsening abdominal pain that started about 4 weeks prior to their admission or presentation, I should say. Their imaging in the ER was significant for enteritis. They were given antibiotics and sent home, but he came back. And this time the abdominal pain was worse, and now they had some distension and abdominal pressure. He also reports some new night sweats and weight loss of about 20 pounds. He denies any recent fevers or swollen lymph nodes that he's aware of. And so the patient was admitted for further workup. On admission, their labs were significant for a creatinine of 1.87. Phos was trending towards abnormal, and their uric acid of 14.9. They had a lactic acidosis as well as an elevation in LDH that was quite impressive, 1399. Their CBC had an elevation in their WBCs as well. So we trended their labs every 6 hours and saw very scary things. Their creatinine continued to elevate, peaked at 3.5. Uric acid peaked at 15.2, and they did receive an intervention, which we'll talk about here shortly. Phosphorus continued to increase, peaked at 14.4, LDH up to 2487, and then the patient became uremic with their BUN of 118 and became confused and somnolent. So what do we think is happening here? So this is an example of tumor lysis syndrome. So tumor lysis syndrome is something that can happen. It's basically just a constellation of abnormal labs related to just high cell turnover. So we see this commonly in diffuse large B-cell lymphoma, Burkitt lymphoma, high-grade B-cell lymphomas, as well as some acute leukemias. And it can happen, without any treatment, but it also can happen once you initiate treatment. So how do we monitor and treat for this? So we want to watch their labs closely every 6 hours and get BMP, phos, uric acid, and LDH. And we want to treat them with very aggressive IV fluids as much as they can handle. A lot of resources recommend at least 200 an hour. This is not always possible, but that's what's recommended. And you want to make sure it's normal saline, not LR, due to the electrolytes and LR. And then we want to treat their specific electrolyte abnormalities. So the hyperuricemia for the patient listed, they did receive rasburicase, which helped bring their uric acid down. You can also initiate allopurinol orally as well. Hyperkalemia, treat that with agents such as Lymphoma, Lasix, insulin combined with dextrose, as well as albuterol. Hyperphosphatemia, and this is treated with phosphorus binders. We like to use sevelamer rather than those containing other electrolytes, just to avoid precipitate in the kidneys. And then they also can have hypocalcemia, but I caution you to replete very judiciously, especially if they have impaired renal function or already have elevated phosphorus due to the precipitate of phos and calcium that can occur in the kidneys. Last patient case, we're getting there. So patient case 3. So this is a 45-year-old female who just had newly diagnosed stage 4B high-grade B-cell lymphoma, and they've been transferred to the inpatient BMT unit to receive their first cycle of dose-adjusted EPOCH-R. She did very well with her chemotherapy portion and is now about to get her first dose of rituximab. You're the cross-cover APP, and you get a call from the nurse about the following symptoms: fevers, shaking, rigors, shortness of breath, hives, low blood pressure. What do we think is happening? What should we do for this patient? So this is an example of a hypersensitivity reaction. This is one of the most common calls that we get on the floor and in the BIC. And this was related to just an overactive or misdirected immune response that can result in local tissue injury and just changes throughout the body in response to this foreign substance. And for this patient, that was the rituximab. And this can be caused by several other factors, including chemotherapy, immunotherapy, biologic agents, etc. So what do we do? Stop the infusion. I would say 99% of the time the nurses have already done that, but always confirm, did you stop the infusion? And then go and assess the patient. Seems like a no-brainer, but go assess the patient. And then you want to give them rescue meds. So basically you're treating this like a big allergic reaction. So even though these patients have already had pre-meds, more than likely with Tylenol, Benadryl, sometimes steroids, we want to repeat those given the degree of the reaction. So they're given diphenhydramine or Benadryl, ranitidine, just additional antihistamine blocking, IV methylpred, and severe cases, epinephrine, which thankfully I've never seen used, but if they have refractory hypotension or there's concern for airway compromise, give the epi. And then supportive care, IV fluids, Tylenol, monitor them closely on telemetry and pulse ox, give supplemental oxygen. And then once the patient's symptoms have resolved, restart the infusion at a lower rate and continue close monitoring. And a lot of times for our first cycle of rituximab or obinutuzumab or other agents, a lot of times the attendings will say, please cap the infusion rate at 100. And that's to hopefully help prevent having a significant reaction like this. But there are some cases in which you will not be able to resume the infusion, such as if you were giving epinephrine, and you'd want to alert the attending as they should know if the patient did not complete their intended therapies. And that is all I have for you. Thank you. Happy to take any questions if there are any. Oh, and also a special thank you to Erin Fahey Harrison, who made up a lot of these slides.
That was awesome. Thank you, Caroline. I was just going to ask about as you start to think about the relapsed patient in
Yeah.
lymphoma,
Mhm.
I'm sure that we'll talk a little bit about this afternoon, but I was a little curious as to how you see the field changing in our approaches to relapse lymphoma, especially as we have sort of more upfront options even.
Yeah.
And what that's looking like for those patients.
Yeah. Well, first you have to think about when they relapse. So is it an early relapse within a year, or is it 6 years down the road? Because that would definitely determine, am I recommending them for CAR T cell therapy, or am I recommending them to retry chemotherapy and get an auto, et cetera? So timing definitely matters. Because we want to know, is this patient chemosensitive or not? So that's the first step. And then the second step is, patient fitness. Because, somebody could relapse, 5 years down the road, but they may not be the same patient that they were previously. And you don't think they could handle immunochemotherapy again and get an auto. They couldn't handle all of that. And then, of course, in the era of bispecific antibodies, that is an exciting time. And I know at SOHO, they presented an abstract about how to sequence, and I didn't get to hear it. So I would love if anyone happened to hear it or knows any idea. But sequencing is definitely an area of intense research as to how do we sequence CAR versus these bispecifics. What do we do first? If someone's had a CAR, are they going to respond to a bispecific? If someone's had a bispecific, are they going to respond to a CAR? What works best first? Do we do checkpoint inhibition? So that, there are a lot of unanswered questions, and I don't think there's a true standard of care, although Erin may know more about this. Well, actually does know more about this than I do. So you're welcome to chirp in, but yeah, it's definitely a very exciting time in lymphoma since we have so many more options for these patients, where it used to just be an auto and pray, and maybe we'll do an allo and you're probably not going to do well. So we definitely have far more options these days. So, yeah.
Thanks, Caroline. Yeah, that was a really great talk. Can you just, I know you referenced CNS prophylaxis a little bit. Can you just talk about the options and kind of where the controversy is with CNS prophylaxis in these
Oh,
patients?
sure. Yeah. So options would be whether or not to give intrathecal chemotherapy, such as IT methotrexate. That's what we would tend to use. And then if patients were found to have actual CNS disease, we would tend to do either triple chemotherapy with methotrexate, hydrocortisone, and cytarabine, or kind of alternate. And then the other option would be to consolidate with a high dose methotrexate at the end of therapy. I can't speak to the exact numbers, but there's been studies that have shown that prophylaxing patients doesn't necessarily decrease their risk for CNS disease or CNS relapse. So that's kind of where the controversy comes into play. But I know at our institution, typically, if patients kind of fall into the high intermediate or high risk, we feel better doing something than doing nothing. So we do tend to prophylax with intrathecal methotrexate if the patients are able to tolerate it. And most patients are. But that's kind of where the controversy comes in. And then there's also patients that are highly opposed to receiving spinal taps, or they get one, they're like, nope, not doing that again. Their kidney numbers are not looking great and we're concerned to do high dose methotrexate, et cetera. So yeah, there's not really a NCCN approved standard of care of what to do. But we at our institution feel better doing something rather than nothing most of the time. Yeah.